Good morning everyone. Today we are presenting a case of ankylosing spondylitis. In this patient, the C2 C3 vertebra was totally fused and he was a case of bamboo spine. The patient was not able to flex or extend his neck and his position of the neck was fixed as is shown in the video. So we decided to go for awake fiber optic as this patient was posted for bilateral PCNL. So here we are giving the local blocks for anesthetizing the airway so that the patient can tolerate. This is the superior laryngeal nerve block. The hyoid bone was difficult to palpate, but still with some pressure we were able to reach it. Here, then we went for the transtracheal block, 4% lignocaine for transtracheal block and 2% for superior laryngeal nerve block. You can easily see that we have a negative aspiration for any blood and the patient is tolerating the blocks well. This is the transtracheal technique. The cricothyroid membrane in this patient was very difficult to trace. Here you can see the aspiration of air. After injecting the local, the patient is coughing, which is a positive sign that we are within the trachea. Now we are giving 10% lignocaine spray both to the mouth and as well into the nostrils. We have used a 7.5 mm cuffed flexometallic tube in this case. The approach in this case was to keep looking for the epiglottis and the vocal cords. You can see that there is quite some difficulty when we are entering because the position of the patient was not an ideal one for the awake fiber optic, but still with the blocks, and we had used some sedation in the form of 1 gram paracetamol with 50 mics of dexmedetomidine and 3 ml of Floxicard. This made, and 20 mg of propofol was given before putting the fiber optic with 50 mics of fentanyl. The patient was sedated well, and with the help of blocks as well, he was able to tolerate the awake fiber optic. As you can see, we have succeeded in placing the tube. After placing the tube, the position of the tube correctly, we have given short acting local muscle relaxant, which is succinylcholine. We are checking the bilateral air entry, and after confirming that with end-tidal, with fixing the tube under vision with the fiber optic still inside, by counting the tracheal rings and by auscultatory method as well. After that, we have fixed the tube, which was at almost 20. The plan of extubation in this patient was awake extubation, since it was a difficult airway, and we were able to extubate this patient successfully after awakening and after he was cooperative and responding to commands. Thank you.